Okay, so today I want to go into some non-system board topics, and I'm going to start with assistive devices, some principles on guarding, on usage, on fitting, as well as, of course, some board questions related to this, and then the gait patterns associated with the assistive devices. Okay, so this starts with kind of defining the assistive devices and also talking about choosing them in terms of stability, in terms of coordination, support, things like that. It does not discuss weight bearing yet. We will be discussing that in another slide. But one of the things that can limit your choices as to which device you pick can be weight bearing status. However, this part does not discuss that. So it is listed basically in order in this chart with the arrows from the most stable to the least stable, if you will. And basically the one that is going to require less from the patient at the top and then more from the patient at the bottom. So starting with parallel bars, do recognize that that is an assistive device. Anything that helps the patient do something, in this case walk, is an assistive device. So parallel bars are also assistive devices. The thing is that they are not mobile, right? So if you look at what it says there, parallel bars most stable overall, but not mobile, because you can't carry around parallel bars with you to walk around the street. But they are an assistive device that gives support, doesn't go anywhere, it doesn't move anywhere. The patient can hold on. The patient can put the full weight. I mean, if you've ever been on parallel bars, you can swing on it. You can think about it like the bars they use at the Olympics. Like you swing, do a flip on it. You could, and it's not going anywhere. Okay, not that the patient's gonna be using that way, but you can, right? So it's definitely very sturdy, very stable, very concrete, very heavy. However, your patient cannot take it with them like they would the other assistive devices that are listed below. Um, it is the best place to start a lot of times your pre-gait training or your gait training tasks when your patient requires a lot of assistance, a lot of hand, um, you know, tactile cues, a lot of um, positioning, a lot of handling is what I meant to say. Because they can hold on, be sturdy. You can throw a chair in there in the back if they need to sit down. You can be in the front. Like you can use it in many ways where you feel that they can hold on and they have a chair behind them and they're sturdy, but they can still work on gait or gait related things, especially if you're thinking of a patient that needs that much help, probably doing more pre-gait stuff than actual gait, but you can of course do gait in there as well. And so that's going to be your patient that has poor balance, weakness, lots of weakness, maybe requires max assist or something like that. That's a good place to start, right? Then we go into our assistive devices that you can actually move around with, which is going to be your walkers, your crutches, and your canes, but I threw in the Hemi walker and cane in there because that's something that we typically use in the physical therapy field, and it kind of falls between the canes and crutches, so I put it between the canes and crutches, or the walkers and canes. But moving on to walkers, so again, walkers have 4 legs, right? They go around the patient, giving an increase and a base of support and support in all kinds of areas around, right? So it makes the base of support wider laterally. It also makes the base of support bigger front to back, right? Anterior, posterior, because of the fact that your patient should really be able to fit in it. And if their feet are right here, they still got all this around to kind of be in and be stable within, right? So that's what makes it super, super stable. And then, of course, those four legs, depending on what kind of walker, some have wheels, some don't. But those four legs give it more legs to support itself, right? So think about if you're standing on one leg versus two legs, how stable you are. Well, if you're standing on two legs versus four legs, how stable you are, right? So definitely you can think of that mechanically in terms of stability. Um, does not really require coordination, right? Like if you can just kind of push the walker forward, like that's it. That's all you have to coordinate, right? You don't have to handle one side and then the other and then not go too far and then the arm pushing here. It's really a little push. I mean, maybe if you have what we call a pickup walker, you have to do a little lifting, but for the most part, it doesn't require a lot of effort to move it, okay? So that little push is going to require some upper extremity motion and strength, but not too much, and definitely easy to use in the sense of handling it. A platform can be added as you see there, so just keep that in mind, because if you think about a walker, both hands are needed to push it forward. But if you add a platform, that can add another perspective to it that can help you with certain patients. But you do need, I would say, two hands to at least be able to give it that push, because if you're only pushing one side at a time, it's going to throw the walker off. So even though it doesn't require too much coordination and too much strength of the upper extremity, you need at least two hands to be able to hold the grips of the walker. And then I did put abbreviations in there. Just keep in mind your board does not give you abbreviations, but just to talk you through the different kinds of walkers. So don't forget that your standard walker or your pickup walker, which is the one with all four legs and no wheels, is of course the most stable because it doesn't roll away. The next stable is your two-wheel walker, and then the next level of stable is your four-wheel walker, being the least stable because it can roll away. But overall, it is still a walker and it is still pretty stable. Then going on to the next pretty stable but not as stable device is crutches. So your crutches do also increase your base of support, and the way that they are positioned when the patient uses them does create some increase of that base of support, also laterally and also anteriorly. Not as much posteriorly to the patient. The patient's feet themselves are the posterior stability, more like a cone-shaped base of support or triangle shaped, I guess. Okay, hexagon, I don't know, like this, right? Like this. But it still increases it in some way. But again, think of mechanically, like now you only have two legs versus four legs, so it makes sense that it's not as stable as your walker. The thing about the crutches is not, it competes pretty well with the stability part of the walker. What makes this one sometimes not the best choice is the balance, the dynamic balance, standing dynamic balance that is required from the patient, because there's really nothing to lean on. Much like the parallel bars, if you kind of put all your weight on the walker, it's holding you up pretty well. Okay, you can lean on it pretty good. You could maybe even lift your body up on a walker and the walker's not going to go anywhere, except maybe if it's a four-wheel walker and you don't have the brakes on. But besides that, if the brakes are on, it's still probably not going to go anywhere. But the crutches, not so much. The crutches, you could easily put your weight on it and one can go one way or something, right? So stability wise, again, it's the second best, right? or the third best if you include the parallel bars. But it's that coordination and that trunk control that you don't really have anything in front of you to like lean on or whatever. It's just things at your side, right? So you really have to be able to kind of hold yourself up. And then coordination, coordination, coordination is the key word for crutches. Like, what makes it better for somebody to pick walker versus crutches is going to be that coordination aspect, which if you think about coordination and just neuro concepts, like how much cognition that also requires, right? Because in order for us to be coordinated, we have to do smooth movements with both sides of our body, and that requires a lot of cognition as well. So sometimes your neuro patients are going to have a hard time with crutches. Maybe the loft strand crutches could work with a lot of our patients, which we do tend to use them with neuro patients, but they have to not have that cognition part be damaged, that impairment to the cognition. Okay. Crutches also require a little bit more of manipulation, dexterity, strength of the arms, because sometimes you have to manipulate each side. You have to grip a certain way, you have to push a certain way, so a lot more upper extremity involvement. So all these things are going to be the things that you want to look for in a question to see if they're trying to guide you to a crutch versus a walker, or away from a crutch, if anything. Okay. And then I also put that your auxiliary crutches are slightly more stable than your loft strand crutches. And the LCFCCC stands for loft strand crutch, forearm crutch, or Canadian crutch, which are the three names for that forearm crutch. Same thing, it has different names. The board is most likely going to use either loft strand or forearm, not Canadian, but just keep in mind that that is another name. Okay. Then we go to hemi walker or hemi cane. So it's a one-sided device. So of course, in terms of stability, it's going to be slightly less. You can put a fair amount of weight on it, but it is not really meant to be a like you lean on top of it type of device, because it's only on one side. So how much can you really put your weight on it, right, for it to be stable without falling apart, versus things that you have on both sides. But some patients just cannot use a double-sided device because they don't have one good side, or they don't have an arm, or whatever the reason is. So they have to use something on one side that's pretty stable, and it's definitely more stable than a cane, like your types of canes by themselves. And just keep in mind again that I use hemi walker. I really only hear people say hemi walker, but hemi cane is out there as another term that you can call it, and there might be somebody out there that calls it hemi cane, so it's the same thing. Okay. And then lastly, canes being your least stable. Number one, because it has one or a few little legs. Number two, it's used on one side. Number three, it's not really meant to hold weight at all. It's more, again, for just like support, balance, like to have something there to give you that tactile cue, that stability, but not in the sense of you leaning on it or putting pressure on it or depending on it. Just that little extra help. What I always say is, if you're ever doing something that challenges your balance, standing on one foot on a tippy toe, see the difference that it makes if you put one finger or one hand on a table versus if you don't. Putting that one hand, even though you're not maybe leaning on it, gives you that sense of like, okay, I can hold my balance. And that's what the cane does pretty much. Okay. And then I did put in order again that the wide base quad cane is going to be slightly more stable than the small base quad cane, and then that is going to be more stable than your standard or single point cane. Okay. And then just keep in mind that there's other devices out there, but these are the main ones that we use. Knee scooter, reciprocal walker, like other things, but you either see if you could put them in one of the general categories. Although typically you're probably not going to get asked too much about stability of these devices, but you don't know, maybe not. So this part is about the fit. And again, I don't want to read line by line, but you definitely want to look up in your sources about the fit. I just want to remind you that you should know about the fit. You should know that for the most part, everything has some sort of hand grip, and it always falls at your wrist, which is the ulnar styloid process, usually the landmark that you're looking at if you're trying to feel for a landmark. That when they hold the hand grip, they should have about 20 to 25 degrees of elbow flexion. The patient, because these are standing devices like parallel bars, walkers, you're standing with them, so the patient should be standing. And they should be standing nice and straight when you're fitting them. They shouldn't be standing like poorly, because then they're going to learn how to use the device that way, and you're going to measure it in that way and create faulty movement patterns, right? The crutches is probably the one that's the most involved in terms of remembering the fit. The other ones are just like, make sure your hand, the hand grip falls right here. But the crutches is like, you got to think about the angling of the crutches, which is about 45 degrees, 2 to 4 inches lateral, 4 to 6 inches forward. The form crutches is different than the axillary crutches. The axillary crutches, you got to think about the finger pads and the axilla. So the crutches is the one that you probably have to put a little bit more effort into knowing all the numbers and all the specifics of them, which are listed here in the slide, as well as, of course, your books. And I do also want to make a note that here in the axillary crutches, where it says 2 to 3 finger widths below the axilla, sometimes they don't put fingers, sometimes they put inches, which I think the inches is also like 1 to 2 inches or something. So 2 to 3 fingers width is about 2 inches. So if they ask you in inches, the numbers might throw you off, because if you pick 2 to 3 inches, that's wrong. It's 2 to 3 fingers width. So just keep that in mind as a little sidebar note. All right, so here's where it gets fun, right? Your assistive devices related to your weight-bearing status, related to your gait pattern, okay? So to me, I've always create these charts. If you've had me in class, I encourage you to create a chart like this, because I'm just a visual person, and charts and things like that help me organize information better. So this is what I like to do, but whatever works for you. But basically, your parallel bars and your walker and your 2 crutches together, like meaning one on each side, will allow for any weight-bearing status. So if your patient has toe touch, partial, whatever, they can pretty much use either 2 crutches, walkers, or parallel bars. There is no limitation between those 3. The one that is limited or left out when they have a weight-bearing status is the cane. Okay, so again, if your patient does not have weight bearing as tolerated or full weight bearing, if they have a partial, they have a toe touch, you shouldn't even be thinking about any kind of cane. You should throw cane out the window, okay, in terms of weight bearing status. Then I put on the other side the gait pattern that is associated with those. Please keep in mind that now 3 points and modified 3 points, which is also called 3-1 point, modified 3 point is also 3-1 point. Now we use that terminology. before, and even in some books that you might read, maybe in your test prep book, they're only saying 3-point. They're not saying modified 3-point. But the current literature does have modified 3-point, so you should be aware of modified 3-point. Otherwise, they'll call modified 3-point 3-point as well. But I don't think the board does that. I believe the board does use the current terminology. So your parallel bars and your walkers only uses either 3-point or modified 3-point. If it's non-weight bearing, it's 3-point. If it's anything else, it's modified. That's it. You only got 2 options. Pretty easy to remember the gait pattern. Okay. It's the other ones, the crutches and the canes, that have a little bit more options. But really, again, it goes back to the crutches being the complicated one, right? Because your single-sided device, like a cane, only has 2 options as well: modified 4-point or modified 2-point. So it's really the crutches that it's like you really have to think: is it 3-point? Is it modified? Is it 4-point? Is it 2-point? Like, there's a lot more options. And if you kind of just focus on that one and you learn the other ones that are pretty easy, then it kind of helps organize things for you, because that's the one that's more involved. But the crutches is basically the one that has all kinds of stuff. So if it's not 3-point or modified 3-point, it's probably a crutch or a cane. And if it's modified 4-point, 2-point, then it's a cane. But if it's not modified, then it's a crutch. But again, you have to be able to organize it in the way that it works for you. Keep in mind with the crutches that your 4 points and 2 points are only for full weight bearing or weight bearing as tolerated. They are not for toe touch or partial, okay? So if your patient has partial weight bearing, you should never be using 4-point gait pattern. If your patient has toe touch weight bearing, you should never be choosing 2-point gait pattern, okay? And then swing to and swing through are in here, and it's not what you think in the sense of like you hopping with one leg or nothing like that. It's both legs swinging. So that would be for your patient who doesn't really have a weight bearing issue. Maybe it's bilateral weakness, paralyzed both legs, spina bifida, something like that, where they can kind of just sway their hips and jackknife a little bit and swing both legs either up to the device or through the device. And that's like a special kind of gait pattern that can really only happen with 2 crutches, because with a walker you can't really you don't have enough space to do that swing, right? So really the crutches are the only open device like that you can do that. All right, so that's kind of going through all the important things about fit, how to kind of choose what's stable, what requires coordination, what gait patterns, all that stuff. Here's just some other things. Keep in mind that the 3-point gait pattern, not modified, just 3-point by itself, is only for non-weight bearing. So if your patient is non-weight bearing, it's 3-point automatically. You don't have to think about it. It's the only option. It's for nothing else. Guard your patient on the weaker side and have your patient lead with the weaker side unless they're non-weight bearing. Then you have to guard to the only side that they have on the ground, which is the strong side, because they can't have the other side on the ground. The guarding position is posterior lateral, and again, the lateral part depends on the side you need to guard. Unilateral devices, meaning things that are on one side, typically go on the stronger side. I'm sorry, I meant to put that is incorrect. They usually go on the stronger side or the opposite side of the weaker side. Okay, they don't go on the weaker side. That's wrong. I think I was thinking of the guarding when I wrote that. But they go on the opposite side of the weaker side or the contralateral side, unless there's a special circumstance, like you can't use the arm on the opposite side or something, then you have to put it on the side that they could use. I mean, what else are you going to do, right? If your patient is falling backwards or forward, usually when we're guarding, because we're standing behind them, we pull them towards us. So just keep that in mind. If they have crutches, they should let go of those crutches. If they're falling, they shouldn't take it with them. And if we're talking about stairs and guarding, when they're going up, you stand behind them. When they're going down, you stand in front of them. If when you're doing the measurements, like the crutches, make sure that they're already in the angled position. If you can do all your measurements of devices with the shoes that they're going to wear for walking, that's even better, because why are you going to do it with the shoes off and then they put the shoes on and they're an extra 2 inches and now the fit is all thrown off? So do it in the way that mimics their walking shoes, their walking clothes, all that stuff, to make sure you get the best fit and the walking posture that you want to promote as well when it comes to fitting. Then just to remind you of the stairs rules: up with the good, down with the bad. However you want to think of good and bad: up with the up with the non-affected, down with the affected, up with the non-involved extremity or the healthy extremity, or the non-surgical extremity, down with the surgical extremity. However you want to word it, however they want to word it, you should be able to interpret it. But the rule is up with the good, down with the bad, right? It doesn't matter if when you're walking you were using the other leg, you were using the good leg. The rule is up with the good, down with the bad, no matter what, when they are starting to gait train, when they are starting to stair train, and they're not able to do reciprocal yet. That's the rule, okay? I'm not going to go through the specifics of, like, if you have crutches going up the stairs, if you have walker going up the stairs, but I will say that the general rule is, if there's handrails, use them as much as possible, all of them that are available to you. And then if you have to take your assistive device with you, you hold on to the handrail as much as you could, and you basically put your assistive device on the other side. But there can be stairs where there is no handrails, and then you just go back to your rule of up with the good, down with the bad, and moving your assistive device with the affected lower extremity. All right, so I think I covered all the topics I wanted to cover today. Now here are some of the questions. First question says, a PTA is analyzing the fit of a patient's walker to prepare for ambulation, and they notice that the patient presents with 45 degrees of elbow flexion. Which of the following actions should the PTA take regarding this observation? Should they A, leave it alone, basically, the fit is proper, the PTA should start ambulation with this walker? B, the PTA should lower the walker? C, the PTA should increase the height of the walker? Or D, the PTA should recommend another assistive device? Let you think about it. 10 seconds. Okay, and the reason why I like this one is because I asked it in a different way, right? I could easily say, what is the angle that the patient should be in? 20 to 25, right, of the elbow. But I made it more interpretive, right? So you have to think about, what does it mean when your patient has more angle in the elbow than what is normal? You have to know what is normal, which is 20 to 25. So that should throw off A, because that's saying the fit is proper and the fit is not proper. But then you have to know what it means to have that much flexion. Is it taller or shorter? That means it's taller, which means that we have to lower the walker. Okay, so the answer is B. There's two options that are opposing, right? Lower or higher. So if you can figure out one of those, then you can automatically rule out the other one. So if it's lower, then it's not going to be higher, right? And then D is just like thrown in there for fun, right? Because there's not enough information in the question to tell you that they should just choose a whole nother device, right? Um, Devices can be fitted, devices can be adjusted, and it's not like, oh man, it's too tall, let me just use another device. Like, that wouldn't be the answer, but it's in there as an option. Okay. Other question about the 65-year-old man. He just had a motor vehicle accident. He's non-weight bearing on the left leg or the lower extremity and on the right wrist. So he has non-weight bearing in both places. Right wrist, left leg. Which of the following is the best assistive device for this patient? You got forearm crutches, auxiliary crutches, rolling walker with the platform attachment, or the four-wheel rolling walker. Okay, so the correct answer here is C. Okay. Auxiliary crutches require hand grip pushing, right? Like you push through the hand grips to kind of lift the body and be able to swing the leg forward, right? And shift your weight. So non-weight bearing for auxiliary crutches, no, no, no. Four-wheel rolling walker, same thing. You should be holding and pushing and putting a little bit of weight through the walker to push it forward with the four-wheel walker. Forearm crutches may seem like you don't have to put weight because they have the little cuff, which is over here, but it still has a hand grip that you're supposed to use and put your weight through. So again, forearm crutches, auxiliary crutches, four-wheel rolling does require the patient to bear some weight through their hands. It might not be a lot, but if it's non-weight bearing, it's non-weight bearing. Non-weight bearing is 0. So not a lot is not nothing. Not a lot is still a no-no, right? So when you push a walker and you kind of put your weight on it a little bit, it's not a lot of weight maybe that you're putting, but you're still putting your weight on it. So if they're non-weight bearing on the wrist, you should not pick anything that requires any kind of weight bearing. The rolling walker, while it is a walker, that platform attachment allows the arm to sit like this in the platform, and then they cannot push through it because the arm is resting like that, especially not through the wrist. Maybe they're pushing a little through the elbow, but the issue is not in the elbow, it's in the wrist. So C would be the best answer. Okay, next set of questions. You have an 18-year-old girl. She had a partial medial meniscectomy of the right knee 1 day ago, so very acute. You're seeing her for gait training. Before surgery, she was basically prior level of function independent, no devices, I'm assuming, and she has no cognitive issues. So a young, able-minded girl, right, that had an accident or that had a surgery. She's partial weight bearing. And then it's asking you not only what is the most appropriate assistive device, but what is the gait pattern associated. Okay. So the way I like to work questions like this, where you have like 2 things that you got to figure out, is I focus on one, and then I see what I could rule out, and then out of those choices, I focus on the other one. So I'm going to start by focusing on the assistive device, right? You have crutches and walker, basically, because A and D both say crutches, and B and C both have walker, okay? While some people may say, well, she can use a walker because it's safe for everybody, including an 18-year-old girl. It may be safe for an old man, but it's safe for an 18-year-old girl too. However, keep in mind that we like to use the least restrictive assistive device, And so a standard walker can be restrictive to natural gait patterns, and she doesn't need to have that restriction for no reason. She's pretty able-bodied, she's young, she has no cognitive issues. Before that, she was independent, so she probably has pretty good balance and coordination and all that. The main issue is that she had knee surgery, right? And she has a weight-bearing status now. But you can almost assume that the rest of her is okay because it doesn't give you any other information to tell you she's not. And then the information they do give you is that she has no cognitive issues and she was independent, which leads you to believe that except for the leg, everything else is working fine, right? So that to me tells me crutches, right? We know young people like to use crutches. Again, age is not the determining factor, but it is true of what we see in real life, right? So that lets me rule out B and C, right? I don't even got to think about what B and C say because I'm not choosing walker, right? So that leaves me with A and D. Now I focus on the gait pattern, right? So you have modified 3-point gait pattern and swing to gait pattern. So the answer is going to be A, right? Because swing 2, I mentioned earlier, it's for your patients that don't have a weight-bearing issue. They're swinging both legs up to the device, and this has nothing to do with what this young lady would do. She would do the whole crutch, step, step, crutch, step, step, which is called, in this case, a modified 3-point. It is not a non-weight bearing, it's a partial weight bearing, so it's not going to be 3-point by itself. Either way, 3-point by itself is not there. There's only modified 3-point and swing 2, and out of those two, the easy choice is a modified 3-point. Okay. The next question says that there's a PTA who is going to recommend an assisted device to a patient with a right cemented total knee arthroplastic 3 days post the surgery. So they had their surgery, this arthroplasty, 3 days ago. They also had a traumatic amputation of the left upper extremity 3 inches below the elbow. So I would say somewhere, I'm trying to show you, somewhere around here, right? 40 years ago. So they basically don't have forearm and hand, right, on that left side. Patient lives home alone. Which of the following is an appropriate assistive device? Again, you don't want to add to the question information they don't give you. So they don't talk about this patient's like balance and coordination and cognition, but we're also not going to add it if it's not there, right? There is no reason for us to assume that, oh, what if they're really old, or what if they have bad balance? Like, it doesn't say it, don't add it. You assume everything else is okay unless they give it to you, okay? So the main issue is that they had this knee surgery, and then the arm is something they're probably used to because it happened 40 years ago, but they don't have a hand. Like, there's nothing you can do about that. They don't have a hand on the left side. Okay, so the fact that they don't have a hand on the left side already should lead you to rule out the walkers, okay, because you need both sides to move and push the walker. It doesn't say anything about a platform or an addition or a modification. It just says walkers. Rolling or standard, either way, you need to push with your hands both sides to push it forward, and you don't have a hand on one side, so how are you going to use any of the type of walkers? So that rules out, to me, A and B. And then you got C and D, but why are we going to put him in a wheelchair? Again, very restrictive in the sense of we want them to walk. They're recommending an assisted device to take home. He might still get a wheelchair to take home, but it's not about that. It's about, we got to get them to be the most independent they can. And if we put them in a wheelchair and don't have them walk at all, that's not good. And again, there's nothing that indicates that that's the level they're going to be at. So hemi walker, it's a pretty easy one. Keep in mind that your cemented total knee arthroplasty typically has a weight bearing status of weight bearing as tolerated or full weight bearing. If it said non-cemented in there, then that patient might be non-weight bearing and your hemi walker might not work. It might have been a wheelchair. If it said non-cemented, non-weight bearing, the answer could have been D, but it says cemented, and cemented people typically are walking and are practically full weight bearing right away, okay, in your total knees. That is something that you learned in musculoskeletal rehab, the cemented versus non-cemented arthroplasties. So the condition does give you a little bit of information, even though you might not have noticed that it did, but it does, okay? And then this is the very last question, which is about understanding how the gait pattern looks like. So in my review, I didn't show you or discuss what the gait pattern looks like, but I suggest that if you still have your PhysioU resource, or you can find videos, or you still have your books, you look at what it looks like. If you are a student of mine, definitely ask me, right? And I can definitely go through what those look like with you. But it's about you recalling, what does a 3-point, what does a 4-point look like, what moves first, and all that stuff. So with this question, you're going to see that first you have to think in your head, which gait pattern do I want? And then you have to read the options to see which of the options is describing that gait pattern, right? So it says APTA is demonstrating the proper gait pattern using crutches, auxiliary crutches, to their patient who is partial weight bearing. What is the proper sequence that the PTA should teach this patient? So I would automatically be like, what gait pattern are they talking about? Which is modified 3-point, because modified 3-point is a gait pattern that you use with crutches, partial weight bearing. And then I got to think about what that looks like. So that's when you move both crutches forward, and then you move one leg and the other leg, and those are your 3 points. Crutches is 1 point, one leg 2-point, that's your 3-point, right? Modified. So the ones that say move the right crutch, then the left leg, then the left crutch, or move the left crutch with the right leg at the same time, then which is A and D, those are automatically out, because in your modified 3-point, you move both of the crutches at the same time. So I would eliminate A and D. A is describing 4 points, and D is describing 2 points. But you don't use that with partial weight bearing. That leaves me B and C. And so the other part that you have to interpret here is what leg moves first. And the leg that typically moves first when you're teaching your patient how to gait is the affected leg. So you move the device, and then, or the devices, and then the affected leg, so that you could put all your weight on the good leg, and then shift over, and then you move the good leg, right? So they should be moving both of the crutches, and then the right leg, and then eventually the left leg, but they don't talk about the left leg there. So the answer would be B, which is move both of the crutches and then the right leg, because the right leg is the one that is affected. Okay, and that's it. That's all, folks.